Welcome to episode 198 of Real Health Radio. You can find the links talked about as part of this episode at the show notes, which is 7, so the word all spelled out, SVVEN-health.com/198. 7 Health is currently taking on new clients. We specialize in helping clients overcome disordered eating, body dissatisfaction and negative body image, regaining periods, balancing hormones, and recovering from years of dieting by learning how to listen to your body. If you're ready to put an end to diet struggles and heal a relationship with food and your body, then please get in contact. You can head over to 7-health.com/help. And there you can read about how we work with clients and apply for a free initial chat. So the address again is 7-health.com/help. And I've also included that link in the show notes. Hey everyone, welcome back to another episode of Real Health Radio. I'm your host, Chris Sandel. And this week on the show, I'm back with a guest interview. And my guest today is Dr. Natalie Gukasyan. So Dr. Gukasyan is a psychiatrist and post-doctoral research fellow at the Johns Hopkins Center for Psychedelic and Consciousness Research in Baltimore, Maryland. After receiving her ND from Tulane University School of Medicine, Dr. Gookalcian completed her internship and residency in psychiatry at Johns Hopkins. She is currently a co-investigator and facilitator in the clinical trials, investigating the safety and efficacy of psilocybin for mental health conditions, including anorexia nervosa and major depressive disorder. Dr. Gookalcian is also a clinician at Johns Hopkins Bayview Community Psychiatry Program, serving patients with co-occurring mental illness and addictive disorders. So I first became aware of Natalie at some point last year. So I've listened to Tim Ferriss's podcast on and off for the last 4 years or so, I'd say. And his podcast was one of the first that I really got into and loved hearing his long-form conversations with well-known celebrities and entrepreneurs. And ever since I've been listening to his podcasts, he's had numerous shows and guests talking about psychedelics and the resurgence in research in this area. And Tim's been a real champion of this and someone who has wanted to see more of it. And last year, he, along with a handful of others, stumped up a sizable chunk of money. I think Tim put $2 million of his own money towards this project. And the money went towards creating Johns Hopkins Center for Psychedelic and Consciousness Research. And the funds are also then for the research to be then conducted over the next 3 to 5 years. They're looking at the use of psychedelics in treating many different conditions. So Tim released a podcast about this, which was a recording of the press conference for the Center's Open. And as part of this, they went through a number of the different conditions that they were going to be doing research on and the people that would be involved as part of this research. And one of the trials that they mentioned was going to be going ahead was with psilocybin and anorexia nervosa, and the person involved was Dr. Natalie Gukasyan. And if you listen to my recent podcast with Will Su, you'll know that this has been a topic I've been interested in for many years now, so the area of psychedelics. And so to discover that there was an active trial looking into anorexia nervosa and psilocybin, like this was super exciting to me. And so I reached out and invited Nelly on the show to chat about it. So as part of this episode, we cover Nelly's background and how she became interested in psychedelics. This is still a taboo topic, although I think this is changing. So we chatted about what it was like to make the decision to move into this area. We then talk about psychedelics and the current research for a number of conditions, so depression and addiction. And at this stage, there hasn't been much research looking at anorexia nervosa and psychedelics, but there are reasons why it's hypothesized that it could be useful. So Natalie outlines all the reasons why they think it could be useful. So looking at biological mechanisms, looking at psychological mechanisms. And this is really a great overview of psychedelics in general and the many ways they work in the mind or the actions that they have within the body. But she speaks a lot directly towards anorexia and why it could be helpful in that area. And then we chat about the current study that she is running or was running, sidelined a little bit at the moment because of coronavirus. But we talk about the intake and the screening process, the psychotherapy component of the study, the psilocybin sessions that occur as part of the study, and then the follow-up and the integration that happen after these sessions. And Natalie talks about some of the early findings that they've seen with the people who've already gone through the study. And I should say that this study is ongoing. So if you are someone who struggles with anorexia nervosa and would like to participate in the trial, you can apply. So if you go to hopkinspsychedelics.org/anorexia, you can apply, and I will link to that in the show notes. And we also talk about law changes that would need to take place, because at this point, psilocybin is still a Schedule 1 substance as part of the Controlled Substances Act. So this would need to be overturned for this to be started to be used in practice again. And so connected to this as well, we talk about the risks of this subject, because while there's lots of positives that we do cover, these substances aren't a panacea, and there are risks associated with them. And this is definitely true with anorexia nervosa. So Natalie is cautiously optimistic, but that caution is warranted. And it's doing studies like this that can help to understand this more. And it was really wonderful to be able to have this long form conversation with Natalie, and we got to cover a lot of information. I'm excited for the work that she's doing, and if things pan out as the early research is suggesting, this could be a useful tool to add to the treatment toolbox when dealing with anorexia nervosa. So that is it for this intro. Here is my conversation with Dr. Natalie Gukasyan. Hey, Natalie, thanks for joining me on the show today. I'm really glad to be talking to you.
Thanks for having me.
So I first came across your name while listening to a Tim Ferriss podcast. He was promoting the new Johns Hopkins Psychedelic and Consciousness Research Center and talking about the different research that was then going to be going on there. And your name was mentioned in connection to a research trial with psilocybin-assisted therapy and anorexia nervosa. And so I instantly knew that I wanted to get you on the show. And so today, I think I'd mostly like to chat about that research trial and the ins and outs of it, as well as talking about what you're doing at the center and Johns Hopkins and psychedelics more generally. But I guess like a starting place, do you want to just give listeners a bit of background on yourself, like a bio of sorts, who you are, what you do, what training you've done?
Sure. So I am a psychiatrist, and I went to undergrad at Cornell University. I studied nutrition when I was there. Eventually went to med school. Between college and med school, I actually took a detour, and I got involved in a lot of cardiothoracic surgery research. And I thought I was going to be a CT surgeon for a very long time, but eventually I sort of came to my senses and realized that in all my free time, I was reading more about mental health, mental illness, and all sorts of other interesting things, like all this psychedelic research that was sort of coming to the forefront. I think the first time I actually came across it, I was a college student. It was around the time of 2008, back when all of the very first papers were coming out of the Griffiths lab, of which I'm now a part. And I was just very intrigued by the findings that they were reporting, that people could have these very intense and very meaningful kinds of experiences that lead to lasting behavioral change and changes in mood, changes in worldview. At the time, though, it didn't really seem like a viable career option to ever sort of end up in that kind of laboratory. But it was always sort of in the back of my mind, and I followed it for quite a bit of time. And eventually, so I was in this sort of limbo period. I was trying to decide whether I should go to med school or pursue a more traditional kind of research route, doing a PhD in probably like biology. And I worked at Columbia University. I was actually a research assistant at their CT surgery lab, and I did all sorts of fun stuff, like fly around with their organ procurement team, and got to spend a lot of time in the operating room, which I really loved. I loved working with my hands, and so for a minute, I was convinced I was going to be a surgeon of some sort. And during med school, it was pretty late in med school, but I had my psychiatry rotation, and it turns out I loved it. And I had to really reevaluate a lot of things in my life. But one of the factors that ultimately made me choose psychiatry was that, in addition to this really interesting kind of career in which I really enjoyed working with the patients, I really loved the colleagues that I had in psychiatry and the things I was just doing day to day. There might be this chance to end up working someday with substances like psilocybin in a clinical or research setting. And so I went for it. After that, I sort of was trying to figure out where to do my residency. And one big factor in choosing was where this kind of work was being done. And among those places, obviously, was Johns Hopkins, probably like the premier place in the world. Maybe not the universe, but certainly the world. And luckily, that's where I ended up. And so I finished my residency last summer, so I'm kind of fresh out. And currently I'm a postdoctoral fellow doing most of my work in the laboratory or in the research setting. And then I also do a little bit of clinical time each week. And my clinical work primarily is in individuals with co-occurring mental health issues and addiction. So I've been at this for, I guess, since last summer, but even before then, as a resident, I spent a lot of my elective time with this group, trying to get my feet wet with what it looks like to do clinical research with substances like psilocybin.
And so what you talked about in 2008 or 2009 when you were reading about it, and that first sparked the idea of I'd like to somehow get into doing the work with these substances. Like, what was it about either the substances, or what was it about what you were reading that was just like pulling you in that direction?
That's a great question. I think it was the first time that I'd seen, you hear a lot of anecdotal stories about these kinds of substances and sort of all the very interesting, amazing, unitive experiences that people have. But it was the first time I had seen that in print in a kind of, premier journal in a professional journal, basically. And people were actually able to show that, not only is it, are people just saying that it's really, intense and interesting and meaningful, but it actually has long-term positive effects that we can measure. Like in some of those early papers, they had not just the individuals rate their behavior and mood changes, but community raters, somebody who knew the person really well. And in general, overall, it just seemed like people were making big changes. And the other interesting thing, right, was that it was like, it's not a drug that you take every day. You have to go fill it at the pharmacy once a month. You have to worry about side effects for months or years. But it's something that's done just once or twice. And even though it's just the peak effects last maybe 4 to 6 hours, the lasting effects can, we're still figuring out. We're actually thinking about maybe doing a longer term follow-up study with some of those early projects. But in some cases, they certainly last longer than a year. And I hadn't heard of anything up to that point that had those kinds of effects, so I was very intrigued by it.
And was there, I don't know at what point you then made the decision to sort of shift and then start working at Johns Hopkins, but did this still feel like quite a taboo topic, and it was quite a difficult decision, and people were saying this isn't great for your career, or had that point passed and this seemed like a really smart thing to be doing?
That's a great question. So I remember, I think one sort of pivotal moment, I remember I was like 2010 or 9 or something like that, and I had gone to the Horizons conference in New York City. It was one of the earlier conferences on psychedelics that were happening. And I'd seen for the first time, medical doctors, PhDs sort of up on the stage talking about their very interesting, exciting work. And they seemed to, they were not exploding or disintegrating into thin air. And I was like, wow, these people actually have viable careers and seem to be doing really interesting work. And so that was that was one of the first moments where it seemed like it might have been a possibility. It's like, well, these folks are making it happen. And at the time, it seemed like a lot of them were sort of later in their career. And I thought that if it ever was a possibility for me, maybe it would happen after 20, 30 years of just doing other kinds of work and establishing myself in other ways. Because for a long time, that's kind of how it went, is that a lot of the quote unquote pioneers of this latest resurgence had been doing other kinds of work before that. And that's rapidly changing too, though. But so I remember that was a pivotal time. But it was still very much taboo, and it was not something I discussed in my interviews as a medical student. Like when I was interviewing for medical school, I didn't really bring it up. And I don't think I even really talked about it in residency interviews, because at the time it was still taboo. And even within the department that I work in, there's certainly a variety of opinions on this kind of work, even like right now. So, so I feel like I had to be sort of tread carefully, but I also made sure to actually be honest and talk with people and my mentors about whether this was a reasonable idea to do. And I'm trying to think back to when this actually, so the time that I actually started to get involved in this work, I was a second year resident. And it was kind of a lucky occurrence, actually, but because I tried as an intern to get involved working with this group, but I just didn't have any time as an intern. Our schedules were so busy, we had no protected time for research. But I was working on the eating disorder unit at Johns Hopkins, rotating with Dr. Angela Guarda, who's the director of the eating disorder program there, and who's a wonderful clinician who I learned a lot from, and I still continue to learn a lot from. And we were just hanging out one evening after admitting somebody, and she mentioned offhand that Roland Griffiths was trying to get her to work on some kind of project with her, but she just didn't have the time to get this protocol written. And I was like, well, that's convenient, because I'd love to help you with that. And that's just how I got involved. And it was very convenient because it was something I could work on in my free time and evenings and weekends. And sort of led to my very early involvement in this protocol. So it's actually been a work in progress for years at this point, getting the actual study procedures down, getting all the regulatory approvals. It's been a while that we've been working on it.
So yeah, I want to go through that bit of research in a fair bit of detail, but just in terms of Johns Hopkins, when did they start doing research into psychedelics again?
So it was around the late 90s, early 2000s that they had started doing this work. And I obviously was not there at the time, but they had really carefully gotten started in this, make sure that everything looked kosher. So it had been a while, and a lot of those folks are still there, like Roland Griffiths, Mary Cosamano. Una McCann was one of the earlier folks involved. She's not working directly in the lab anymore, but a lot of those people are still there.
And then when did the new center open?
So the center designation officially happened in September of 2019. And that was also I feel very lucky to have just come on to the scene right when the center designation happened. I feel like I was lucky in a lot of ways, but yeah. What it means basically is now that thanks to folks like Tim Ferriss and the Cohen Foundation and others, we have, and thanks to my faculty colleagues who had worked really hard for years doing this kind of work to make a name for themselves and secure this kind of, develop these relationships and secure this kind of funding. There's basically now funding to cover this kind of work for about the next 3 to 5 years. One of the issues for a long time was just that. It was the money and the ability to actually have the time and resources to do that work, because obviously, a lot of the traditional funding agencies like the NIH were not at the time providing a lot of funding toward projects like these.
And then what other research is going on at the center? So obviously you're doing the research with psilocybin and anorexia nervosa. So what are the other bits of research being done with psilocybin?
Well, at the moment, there's coronavirus. It's sort of really throwing a wrench into things. We've just been talking about that.
Yeah. So yeah, where are you up to because of coronavirus? How has that affected you guys? Like just everything is stopped.
So for the most part, almost everything at the university that is human subjects research has come to a halt, unless it's coronavirus research or research that cancer drug research, things like that, where if they stopped, they would cause serious harm to folks. And we tried to do everything we could to be able to continue doing this work, but really just obviously, given the state of things currently, it wasn't feasible.
Yeah.
So we're on hold in terms of recruiting new people. And we can't do any in-person assessments at the moment, but we are still, we're all working from home. We're still reviewing applications and things like that, and doing our best to make sure that we're well positioned when everything opens back up again. But before all this happened, we were engaged in a number of projects, and so with the center designation that came with kind of like a 5-year plan of all the different projects we were going to be doing, and we've gradually been rolling those out. So anorexia, that study was one of the first to roll out. There's also a recently launched study looking at the effects of psilocybin in people with mild cognitive impairment due to Alzheimer's, who have co-occurring mood symptoms. We're currently a site for a multi-site study of psilocybin for major depressive disorder through USONA, who is our sponsor. It's one of the 2 big organizations who are doing these large studies right now. So that's sort of a phase 2 study, and eventually, hopefully, would be rolled into a phase 3. And it's a randomized, placebo-controlled trial. And I believe there are about 7 sites involved, and about 3 of them are actually active at the moment, or were active before COVID came onto the scene. But there's a lot of other planned studies, and we're diligently working to get those rolling. So some of the other studies that we're trying to launch include a study for folks with PTSD, obsessive compulsive disorder is another thing it's on the horizon for us, opiate use disorder. Another project that might be coming on hopefully this year is going to be a study on people with co-occurring major depressive disorder and alcohol use disorder. And then there's a handful of studies that will be happening in people with, in healthy people, basically looking at the effects of these substances on creativity and well-being, personality, things like that. In the meantime, we're doing a lot of survey studies, which can be done on the web. That's probably our main focus right this second, because everything else is dormant.
Well, look, with the survey studies, I will get the link details for you or from you, and I can put them in the show notes. So if anyone wants to go on and fill that out, then they can. So
that'd be much appreciated. Yeah.
I guess, like, just as a starting point as well, do you want to define psychedelics? And I know I recently did a podcast with Will Su where we chatted a little bit about this, but I don't want to assume that everyone has listened to that or aware of what the term psychedelics mean. And I just think we're going to probably use it a lot as part of this episode, so listeners are on the same page. Sure.
So there are a bunch of different definitions and even a bunch of different terms used for psychedelic substances right now, but the term that we tend to use is psychedelics, and we mean those to be drugs that are considered classic psychedelics, which function primarily through they exert their effects primarily through a specific type of serotonin receptor, the 5-HT2A receptor. And so that family of drugs includes the prodrug psilocybin, whose active form is psilocin in the body. It includes LSD, DMT, mescaline. And there's a couple other drugs that are kind of sometimes lumped in with psychedelics. So that includes MDMA and ketamine, but those actually work by different mechanisms of action and have different abuse liability, meaning they may have a higher likelihood of creating dependency in somebody. And so we do consider them, at least at the center, to be different classes of medications. And what happens when you take a psychedelic is that you have these acute changes in perception, in somatic symptoms, psychological changes, but they tend to be kind of pretty well circumscribed, and they differ in the duration of their action. So psilocybin has effects that last about 4 to 6 hours, and some of the others are shorter or longer. And there are sort of different descriptions of what they're like phenomenologically for the people who are taking them, but the probably one of the bigger distinctions is the duration of action for those.
And is that part of the reason why you guys are using psilocybin, just because of the length of time?
So it's one of the reasons. I think the other reason is just that we have so much experience with it at this point. We've demonstrated clearly at our center that these substances that psilocybin in particular can be given safely in a supported environment. So it's not easy, but it's more feasible for us to propose new studies working with this substance. And we also have some on hand, so that's sort of convenient too. And
so just for anyone who doesn't know what psilocybin is, can you just describe or define what it is?
Yeah, so psilocybin is it's the prodrug, and so the active. So when you eat psilocybin, your liver turns it into psilocin, which is the actual drug. And so psilocybin is found in hallucinogenic mushrooms, or magic mushrooms as they're called. There are many different species, about at least 200 of them, that contain psilocybin in varying concentrations. And so that's the most common way that they're found that psilocybin is found just out in the wild. But at our lab, we actually use a synthetic version of psilocybin that was made in a lab, which we, continually test for purity and make sure that it is what we say it is, and the dose is actually correct. It's a little bit harder to sort of gauge some of those things when you're using like a dried mushroom, which also contains other kinds of chemicals in it that can be mood altering.
And so with psychedelics or with psilocybin, what is the current state of knowledge around it for things like depression and addiction? And then if there is anything on anorexia nervosa that you know of? Yeah,
so we sort of started talking about, some of the earlier studies using psilocybin. There's also this very rich history back in the 50s to 60s to 70s, where there was sort of the first wave of research with these substances, primarily with LSD. And then everything kind of came to a screeching halt in the 70s due to some legislation that had come out that sort of didn't look very favorably upon these kinds of substances. But back when this sort of came back online in the early 2000s, we started working with healthy people, and then moved into people who had end-stage cancer, and were also struggling with anxiety and mood changes related to that. And from there, we saw that, clearly it has some benefit for anxiety, depression. So what would happen if this was tried in other sorts of populations who didn't have cancer, who just had straight up major depressive disorder? So there've been a handful of studies on that so far. There's a group out in London who published in 2016. There's a paper where they gave 12 people a couple of doses of psilocybin, basically like low to moderately high doses, who had treatment-resistant depression. And they found that there was a 50% reduction in symptoms generally, and this was sustained at about, I believe it was 3 months. So that was very interesting, obviously, right? Because treatment-resistant depression is no joke. It's in addition to just suffering with it, there's also the constant changing of medications and therapies. And so the fact that there was a 50% reduction in symptoms in a lot of these folks was pretty remarkable.
Yeah.
We are on the tail end of another depression study. So this is separate from the multi-site study. But we did a randomized waitlist control study. I think it was about 24 people with major depressive disorder, didn't have to be treatment resistant. Our group had presented some of the initial findings at a conference last year. And basically we found that the majority, so over 80%, had a clinically significant response to psilocybin within a week and also at 4 months. And about half of people achieved remission. So they sort of met the depression score that said like, oh, you're not even really depressed anymore at about a month, which is pretty remarkable. So that was some of the early findings that we had. And we're working on putting out the full initial findings from that study this year. So that should be available pretty soon. There's also, so in terms of addictions, right? So that's sort of a developing field at the moment, but probably the most prominent findings there include a study in smokers that was done at Hopkins by my colleagues, Al Garcia, Matt Johnson. They looked at a group of people, about 15 folks, who got, I believe it was 2 to 3 doses of psilocybin, 20 to 30 milligrams, in conjunction with this CBT intervention that they did. It lasted 15 weeks. And remarkably, the majority of folks, about 80%, were abstinent from cigarette smoking at about 6 months. And so this clearly, even though it's a small group, it's pretty remarkable because a lot of the other available treatments for smoking don't achieve anywhere near those kinds of results. And a lot of them continued to be abstinent at 12 months, about 60%. So for smoking, there's also another ongoing smoking study at the moment. They're sort of using a larger sample, and they have a control group of some sort. Usually, I think it might be treatment as usual with nicotine patches. For alcohol use disorder, there was a group at NYU who had published on that a couple years back, and they found that I believe it was 1 or 2 doses of psilocybin was able to decrease the amount of heavy drinking days for people with alcohol use disorder. So those are the main psilocybin studies that I'm aware of for addiction. And so it's all very impressive, but I think the other thing to remember is that these are very small studies.
Yeah.
There's some issues in some of them with adequate placebo control, which is probably do an hour just on what that's all about to begin with. But that's a very thorny issue, obviously, in a lot of this research. It was like, well, placebos are the gold standard, or placebo-controlled studies are the gold standard, but how on earth do you achieve that with a substance that causes such profound subjective effects, right?
And so in terms of then anorexia nervosa, have there been studies on this before? And even if we go back to the 1950s or 60s, had there been studies done then?
So there had been reports of people with anorexia nervosa receiving drugs like psilocybin. I think it was primarily LSD in most cases. But part of the trouble back then, and part of the reason that the current resurgence in research has sort of gotten so much attention, is that there's a lot more rigor in what we're doing. So back then, if you look at a lot of the research, much of it is case series, or barely that. It might just be like, oh yeah, we saw 100 patients. Some of them were depressed. Some of them had, some kind of neurosis or some sort of diagnosis that isn't even used anymore today. And, in general, they did fine. And that was the research. And so obviously that's not something that we can point to in 2020 and say that, yeah, this is definitely safe for consumption. So there were I'd come across a couple of mentions in a handful of papers. Some of them saying that this might have been helpful. Some of them sort of reporting on adverse events that had happened. I remember one in particular was using just extremely high doses of LSD, something like 800 micrograms multiple times in a teenager, somebody who's not even 18 years old with anorexia nervosa. And surprise, she didn't have a very good outcome, and she actually probably had suffered some long-term damage from that. So that's kind of the state of knowledge about anorexia nervosa that we have from the earlier wave of research, is that in some cases it was done. It wasn't really very well documented. But obviously we have started this research study because we believe that it might be useful. And the reason that we think it might be useful is just it's sort of a manifold proposition here, and part of it rests on a biological reason, part of it rests on a psychological reason or reasons, which I'm happy to talk more about too, right?
Yeah,
so
definitely go through each of those bits.
Yeah, so in terms of, I feel like in general, there's two kinds of stories that are told about these substances, right? There's especially since 2000, there's like the very interesting biological aspect of this. We have all this nice imaging research. We know a thing or two about how neurotransmitters are involved, but there's still very much to be learned on that front. But we do know that psilocybin and drugs like it affect something called the default mode network. So the default mode network it's sort of a big network in the brain of parts of the brain that are talking to each other when you're doing nothing in particular, when you're just kind of twiddling your thumbs or daydreaming. And it's just sort of involved in, the process of being, of like me-ness in the brain, sort of thinking about yourself, thinking about other people, things like that. And so we know that when somebody takes psilocybin, there's a disruption in this network. And so there's a disruption potentially in the sense of self that can happen. We also know that there are longer term changes that can happen as a result of psychedelic use in the function of the amygdala, which is a part of the brain that's involved in emotional responses. So Fred Barrett out of Hopkins has done some work on this. He's shown that some early results basically that shows that there's decreased reactivity in this part of the brain when it's shown emotional faces. So negatively valenced emotional faces. The amygdala doesn't react quite as strongly.
Is this like post having the substance, or are you meaning while the substance is still active within the individual?
So this is post having the substance. So they have a baseline scan and they have some follow-up scans after that.
Okay.
And so in the follow-up scans, they just don't have as strong a reactivity. So that's one thing that we know happens with psilocybin. There's also some studies about what happens in the acute state, done by groups outside of ours, which a lot of folks might have seen these very compelling images of like, well, this is your brain normally, and this is your brain on psilocybin, where it has all these like interesting connections from parts of the brain that don't normally talk to each other. They're now talking to each other. So that's sort of one thing that might happen, is that it might kind of loosen up the normal networks in the brain, temporarily at least, during the acute drug effects. And the other thing we know about is obviously that it works through this serotonin 2A receptor, and that if you block 2A receptors, for the most part, you block any of these subjective psychedelic effects that can happen. And the 2A receptor, we know it's involved in a lot of different things, but so we know it's involved in some cases in depression. There's some evidence that it might be implicated in anorexia nervosa, but the evidence for that isn't quite as strong. So one of the hubs in the default mode network is called the angular gyrus, and it's found to be more active in people with anorexia nervosa. And when people recover from anorexia nervosa, that kind of corrects itself, at least partially. And so the angular gyrus is involved in this finding, and the angular gyrus is associated with changes in interoceptive ability in people with anorexia. So people, when we think about sensing what's going on in your own body, or your sense of like, what the sensations are coming from your own body.
Yeah.
And there's a couple other things with the serotonin 2A receptor and anorexia. For example, there's some overlap between OCD, and in some cases they found it with anorexia as well, is that there's this genetic marker, this kind of version of the 5-HT2A promoter region. It's sort of the part of the gene that sort of is involved in actually transcribing and getting this receptor from the gene into the cell. And that is affected in both OCD and anorexia. And now we know that OCD actually does, in some cases, in some small study that has been, a couple of small studies that have been done, has shown that it might be effective. Psilocybin might be effective for relieving symptoms of OCD. So those are some of the biological kind of reasons that we think that it might fit or work with anorexia nervosa. There's obviously then like the the two stories, right? So there's the biological part, and then there's all these very interesting subjective effects that people talk about and psychologically mediated mechanisms that people talk about. Within psychedelic research, there's a lot of talking about like mystical experiences, and some folks have a hard time with that term because it doesn't sound very scientific. They might choose to call them peak experiences or flow experiences, things like that. But basically, it actually is a pretty well validated construct and something that we have found a way to measure pretty reliably. So when we think about mystical experiences, there's probably the chief component is this aspect of unity or feeling interconnected to a lot of different things, connected to yourself, to to people around you, to the universe in some cases. So there's this feeling of unity. There's a feeling of sacredness or reverence, deeply felt positive mood. A lot of folks who have these kinds of experiences say that they actually can't describe them in words. They're sort of ineffable, which makes it a little bit difficult to study in some cases. But the interesting thing is, if you look at some of the earlier studies, they actually found that the more mystical somebody said their experience was, the better long-term effects that they had. So even though it sounds a little bit out there, it's actually something that we've seen over and over again, and it's something that's actually positively correlated with good outcomes in folks. So the mystical experience is one aspect of the psychological mechanism. So Roland Griffiths has also coined this term ontological shock that can sometimes happen, meaning that the experience is so different from anything that someone has come across before that they might really reconsider their worldview or their personal view on things, or it might lead to changes in psychological flexibility. So ontological shock is another kind of thing. In talking with people who have been through this, there's oftentimes a lot of stuff that comes up around insight that they might develop into some of their personal issues, their relationships, their own emotions. So that's obviously potentially involved there. People report this increased sense of openness, and we've actually shown that openness is a facet of personality that's pretty well validated in people who have undergone psilocybin-assisted treatment. They have actually shown that they have increased openness in their personality inventory months out, which is pretty remarkable, and not something that I've seen any other pharmacologic intervention accomplish before. Interestingly, the only other intervention I know of that does that is psychotherapy, and there's obviously quite a bit of psychotherapy wrapped up in this kind of treatment. But so that's one other thing. One interesting thing is that people could report this greater tolerance for discomfort. So like in the smoking study, an interesting finding was that a lot of people reported that they still had a lot of the withdrawal symptoms of tobacco cessation, right? So they stopped, they would get kind of sweaty, nervous, their appetite would change, but they actually were just not that distressed by it as they otherwise would have been.
Is that in any way connected to the fact that within these mystical experiences or peak experiences, there are points at which they are very enjoyable and there are points at which they can be extremely difficult or terrifying or whatever? And if someone has had that kind of the kind of scarier end of that spectrum and then made it out the other side, it I don't know, changes their perception about what they're able to handle in real life.
Yeah, so that's certainly a part of the experience for a lot of people. And what some of the earlier studies here, I think something on the order of 20 to 30% of people reported a challenging experience like that. But the challenging experience was actually not really related to negative long-term outcomes. And we think probably for reasons just like you just said, right? So if you go through an ordeal and you come out alive on the other end, that actually might boost your confidence, and it might sort of show you or teach you that hey, maybe you can actually tolerate much more than you thought that you could. Yeah. But that's also kind of like an interpretation, right? There's not really any way for us to ever prove that or falsify that. But that makes sense, right?
Yeah, definitely.
Yeah. So there's that. And there's also, I mean, I'm a fan of this idea that there's something very something about the experience that's tied to mindfulness. Do you have much experience with mindfulness, Chris?
I have some experience with mindfulness. I'm not very good at mindfulness in terms of like when I try and meditate. I have tried and failed repeatedly.
Yeah, so it's obviously a very tough thing. And so that's something that we hear quite a bit from people who try to practice mindfulness, right? It's like, it sounds great. Like in theory, wow, it sounds perfect. It's all my problems, but actually sitting down and doing it, and also having it explained in a way that actually makes sense, given that it's in some ways, you can't really put it into words either. It really takes a very skilled teacher and a lot of like dedication and determination to a mindfulness practice to actually achieve anything resembling like what we hope somebody would achieve with a practice of mindfulness. But some of the ways that people describe feeling after the psilocybin experience is really harkens to what people say after they have a pretty well developed mindfulness practice, right? That there's sort of there's less chatter going on in their heads. They're more able to separate themselves from whatever monologue is going on about this or that, or some focus on the imagined future or the remembered past, which might be misremembered and not actually reflect reality, right? They're sort of more present.
Yeah.
And I think that, in one sense, it might be substances like psilocybin might be a way to give somebody that kind of like experiential knowledge of what that feels like. And sometimes it might happen during the acute effects. A lot of people have this sort of like afterglow period in which they just feel more at peace in that way. But how that works is another story. And I'm not sure that there's a very easy way to figure that out, right? Because, okay, you take psilocybin, everything gets all jumbled up. And after that, there's this kind of calm that kind of comes over. And the calm can be pretty long lasting. And I think that's also one of the most like fascinating things about this whole thing is that, even though the intervention is so short, whatever happens in that 4 to 6 hours, in many cases, is something that the person who undergoes it can take with them for a long, long time. And in many cases, people in the early studies, I think one of the most impressive things is that people said this was like in their top 5 most meaningful experiences in their whole life, which is really saying something, like that it's sort of up there with like the birth of a child or the death of an immediate family member or something like that. And a lot of people have trouble hearing that, right? They're like, well, what kind of life have you led that this is one of your top 5 most meaningful experiences? But for many, that's kind of just what it is. And it's really hard to describe in words what it means.
Yeah. And look, I mean, just connecting back to the mindfulness piece, like while I'm terrible at meditating and trying to do sort of mindfulness in that way, I'm very much aware of like my thoughts are just a stream of consciousness. Like they appear in my mind. I'm not the author of my thoughts. Like I kind of get mindfulness in theory a lot more than I'm getting it in practice. And I know, like, I'm a big fan of Sam Harris, and he's done a lot of work around mindfulness. And I know he got his start with being interested in all of this because of quite a lot of psychedelics. And so I have a lot of listening that I've done around that. It's just in terms of me and a mindfulness practice that is still yet to be seen.
Yeah, well, I mean, I think there's also a difference between sitting meditation and like the whole point of sitting meditation is to get to a place where you can take what you experience there and just bring it to everything in your life, right? Like you could be mindfully eating, mindfully walking, mindfully washing the dishes, etc. Like, so it looks different for a lot of different people, but when you sort of sit down with somebody who's never heard of that idea before and you sort of tell them like, oh yeah, that monologue running in your head is like, it's not actually you. It's very confusing and very distressing in a lot of cases, right? Like, well, if it's not me, then like, who am I or what am I? And I feel like with psychedelics, what might be happening is that, well, there's this like utter destruction of that construct, right? Of this thing that you thought was you, and yet there's still some part of you that's left, that's observing that. And being able to be shown that in that way, it can be extremely powerful for folks. On the other hand, though, like many people come out of it and still don't really see it that way at all, or they might have had just like a completely, like a very intense somatic experience. They'll have like a lot of movement, or talk about a lot of perceptual changes they had, and not really relate it to like a mindful state in any coherent way, but still sort of come out and look as if they might have just done a mindfulness-based retreat or something like that.
Yeah. And so let's talk specifically then about the study that you're doing. So you said that this has been kind of years in the making, in terms of you putting this all together. So let's talk about what the study is gonna look like. And I've got various questions that I want to ask around this, but I'll just open it up to you. You talk about what it's going to be.
Yeah, I feel like I didn't actually get to the psychological reasons why we think this might work in anorexia, but in short.
Okay, so let's go back to them. So yeah.
So in short, the phenomenologically, there's a lot of overlap between the symptoms of anorexia nervosa and some of the other conditions that psilocybin has shown some early efficacy for, right? So with anxiety disorders, with OCD, addiction, right? You can sort of tie a lot of what people experience in anorexia to those kinds of symptoms, this kind of rumination, this being very fused with what's going on in their head, be it thoughts about, anxious thoughts about food, sort of addictions or behavioral patterns that they find themselves kind of locked in that they can't really break free from. And so that's sort of one possible reason that it might work, is that maybe there's a lot more similarity between anorexia and other sorts of mental illnesses. There's also a really high rate of comorbidity between anorexia and other mental health issues. So it tends to be more the rule than the exception that folks with anorexia are also struggling with anxiety disorders, with depression. And perhaps if we can help them with those other issues, then they might have an easier time handling their eating. And exercise and other sorts of related things. And then finally, there's a little bit of anecdotal evidence. I think you'd asked before, what's the evidence like? So there's actually not a ton, apart from there's obviously those early kinds of parenthetical mentions of what happens to people with anorexia under the influence of LSD and psilocybin. But more recently, there have been some reports of naturalistic use, so use in the community of other psychedelics like ayahuasca for people who have issues with eating. But that was a paper from Adele LaFrance, who's up in Canada. And so she sort of surveyed folks who had went to these ayahuasca retreats and had a self-reported history of bulimia, anorexia, binge eating disorder, about what happened to them if they had any benefit. And some of them did. In general, it seemed to be, didn't have she talked about the risks of doing so, and some people did experience some worsening in their symptoms, but many or significant part also experienced some improvements. And so that's why we sort of started looking into psilocybin as a potential therapeutic agent in conjunction with a nice sort of psychotherapy package. And so those are some of the reasons that we thought about it.
Yeah.
And the study,
and just in terms of the comment you just made there about ayahuasca and whether it was then helpful, I know when I chatted with Will Su, he was talking about the fact that, yes, these substances are important, but they're part of a bigger package where you then need to do the work going into, coming out of, do integration, all of those things. So I would be interested, as part of that study, was there all of those other components, or was it simply just people going to this one retreat and that was kind of it in terms of follow-up?
Yeah. So again, this was just people who had gone and done this on their own for the most part. I imagine some of them might have had some kind of contact with, a mental health professional or even, a friend or something to talk about it, to try to integrate it. But this was not any sort of formalized approach to integrating the experience or preparing them for the experience. So that's one big difference about that. And also just the fact that obviously the environment is really different. They're going off to these retreat centers, and that in of itself, I imagine, is kind of an ontological shock to be, halfway across the world Though in some cases, I guess there are people who do it locally in sort of an underground setting, but that in and of itself might be a big difference in terms of outcomes there.
Oh, totally. And I mean, I know from working with clients with eating disorders, like you put them in a new novel environment, and that's a really big stress in terms of eating behaviors. So to hear that someone went to a retreat halfway around the world and their eating got worse is like, for me, I'm like, that's not a big surprise.
Right. And that's something we've tried to work with a little bit in our study, because a lot of our participants and people who have applied for the study or who we've screened are actually from out of town. And so that's sort of one challenge for a lot of folks who have been in the study so far, is that, not only are they doing this unusual sort of approach to treatment, but they're far from home. They're living out of a hotel for a little while. And so we're trying to figure that part out at this moment, now that we're actually off the ground. But like in the early days, we were just trying to put together what would make sense for a treatment protocol and therapy for these folks. So, I guess some good background would be like what the usual setup looks like in clinical studies with psilocybin that we had done prior to the anorexia study. So it generally looks like about an 8-hour total preparation period. Usually it's done over about 2 days. Where a person hangs out with us in this treatment room, which looks kind of like a living room. It's got couches set up and comfortable chairs and nice decor and tasteful lighting and things like that. And we get to know them, and we develop a sense of rapport and trust with them. And it actually tends to be pretty intense, right? Because usually in psychotherapy, you're coming in and out for 40 minutes or an hour, and over the course of months, or, you might sort of develop enough rapport, but this is sort of squashing, essentially 2 months of psychotherapy into a couple of days. So it can be very intense, and it can, that in and of itself probably might be therapeutic, So normally they have this 8-hour preparation period, and then they have their psilocybin sessions. They're all day long. Usually there's between one or three separate sessions where the person comes in, we sort of get them situated, they take the medication, and we sort of lay them down on the couch. They have eye shades and headphones on. The headphones are playing this pre-programmed set of music. It's a combination of like classical music, world music. And for the day, it's actually it's pretty non-directive. We're not really sitting there telling them, like, oh, try this or do that. We're mainly there as a source of support if they should have a really challenging time, if they feel like it would be helpful for them to talk about what's going on, or just to have somebody to hold their hand or put a hand on their shoulder, and to help them, if they need to walk to the bathroom or something like that, make sure they don't fall, things like we're just looking out for their safety, and we're monitoring them for any health issues that could come up, like blood pressure issues are pretty common. So they have a couple of those, and then they have usually some integration sessions around that. And what that means is just a follow-up session. Usually there's one the day after their psilocybin session, and then maybe a week out, and then some other follow-ups over the next month or two, where we talk about what happened, get the person's take on what it means, help them make sense of it, help them integrate, quote unquote, their experience back into their daily life, right? Because you're not going to be on psilocybin all the time. It's really just at least in the context of this study, just once or twice, maybe 3 times that they're going to be doing it. And so what the important part is sort of the work that's put in around that, just like you said. So that was sort of the base for the study, or the model that had been used at the research center for a while. And in adapting that to anorexia, some of the considerations were obviously folks with anorexia can be kind of clinically complex. They might have a lot of different issues going on, and they might benefit from a kind of maybe a more structured approach, or an approach that sort of lasts a bit longer to make sure that relationship develops with the facilitators in a productive way, basically. It's meaning so the person can really learn to trust them, because obviously for a lot of folks who have anorexia, there's it's not uncommon to hear that they had a kind of a contentious relationship with their treatment team. So we really try to ease into that kind of relationship with them and really make sure that we're on the same page together. We took so some of the studies that we had done before used kind of a regimented approach. So like smoking, for example, used CBT as their therapeutic base. And a lot of the other ones were kind of open-ended and just, like, let's review your life story. Let me just tell you what's going to happen in the psychedelic experience or like on your session day. And so we kind of took a mishmash of that, and we used motivational interviewing or components of motivational interviewing to develop the therapeutic container that this is sort of developed in. And the reason we did that, motivational interviewing, or MI for short, MI is based in this kind of collaborative, compassionate approach with mutual respect and sort of trying to take a patient's point of view into consideration as carefully as possible, which is, I think, really important for people with eating disorders who might have had these kind of negative experiences with treatment in the past, right?
Yeah. And motivational interviewing is kind of at the core of how I work with clients, and it's had a big impact on me. So yeah, that's something I'm a big proponent of. Yeah.
So so that's sort of what we tried to do. And so it looks like this kind of Frankenstein version where we take this MI approach to communicating, but we also just do the usual stuff where we review what's happened in their lives, what's happened to them in treatment before. We talk about what their values are, why they're here to begin with, how they feel about change in general, where they're at in Prochaska, Di Clemente's stages of change. It's, those pre-contemplation, contemplation, action, preparedness, maintenance, whatever. So we talk about that and sort of get them to think about, where have they been in that before? Have they been in recovery before? How did it feel? What were the circumstances going on at the time? And so we sort of get them thinking a little bit more about that. We do offer like an optional nutritional counseling. So that was sort of a big issue here, right? Is that like, with depression, things like depression or smoking, obviously like, you might just change and you might just not want to smoke anymore, or your depression might just lift, and like, wow, good for you. There's like not very much to be done after that in some cases. In many cases there is, but with anorexia nervosa, you still have to do the work, and the work can still be very challenging, right? Doing psilocybin is not going to change your eating behaviors or your exercise behaviors. Ultimately, that comes down on the person. And so we do have kind of a more behavioral focus at times, sort of a little bit different from the other studies we have done, where we talk about like, all right, well, what are you doing? And that sort of happens a little bit more after the psilocybin sessions, right? So they've had this experience, they might have had things shaken up a little bit. Now what? Like, what was going on before? What do you want to change? What are you going to be doing? How can we support you through that? So they have this preparation. It lasts about a month, where we meet weekly with them for a couple hours at a time. So in total, it's about the same amount of time, but it's split over longer. So it might feel kind of like we have more time to develop a relationship, but we could see them more frequently if we want to. Our protocol allows for that. And then they have 2 psilocybin sessions. So the first one, it's a moderately high dose. It's 20 milligrams. It's not weight-based. That was sort of another consideration here, is that many of the other previous studies had done a weight-based dosing. So obviously for folks who are underweight, that could potentially lead them to have a dose that's low enough to not really do very much. And anecdotally, there was also some concern that people with anorexia might be less sensitive to these kinds of drugs to begin with. So we tried to do this fixed dose approach for now, where they get this 20 milligram dose first, they have a couple of follow-up sessions, and then they have a second dose of 25 milligrams. And then following that, they have a month of more integration, which is actually a little bit more than is used in some of the other studies. So we kind of figured that these folks might need more help around integrating it, about behavior change and things like that. So there's a more intense integration period or follow-up aftercare sort of plan than for other studies that have been done before. And that's, again, where we talk more substantively about the ins and outs of like the nuts and bolts of what they're actually doing day to day.
Yeah.
And then we follow them up for a period of about 6 months, sort of gradually tapering the frequency with which we see them. So that's kind of how it stands now. We launched back in around the time of the center launch. We opened up for applications and things like that. We've ran a handful of patients at this point, or participants at this point. Obviously, we're stuck because of coronavirus and pandemic. But we have a little bit of information at this point, and that's kind of where we're at right now is looking at everything we've got and trying to understand what has worked, what hasn't worked, and that we have this kind of built-in breather period to try and determine if something, if this is really the right approach, if something needs to change. In general, though, I think it's a little bit too soon to really say, but we're trying to figure that out right now.
And so in terms of total numbers of participants, what was the aim when you first set up the study?
So we said we wanted to get 18 over the course of about 3 years. And I think we're doing pretty well, but then we got derailed, unfortunately. It was just really unfortunate because we had started working with a couple of people and we were partly through the preparation period and we had to stop. And we're trying to figure out what to do with those folks and how to proceed there. And
in terms of, are there things that would disqualify people, just that come straight to mind where you're like, okay, if this is going on, then we can't have them as part of the study? Yeah, so to be in the study, somebody has to have a current diagnosis of anorexia. They have to have had it for at least 3 years. So we're really looking at people who clearly have been struggling with this for quite a while. And they also must have had at least one go at treatment. And that means either an inpatient admission, a residential admission, a partial hospital treatment, or a certain period of outpatient treatment that they have had with somebody for the purpose of treating their eating disorder. They have to be medically stable, right? So if they're at a point where they would require inpatient care, residential care, they probably wouldn't be appropriate for this study because they have to be able to be medically safe, right? And if we're not in a position to care for somebody in that way, then they probably wouldn't be a good fit. One of the other challenges for this and every other study looking at psilocybin and related compounds is the fact that they have to be off of any serotonergic medications. So that includes SSRIs, tricyclics, the other usual suspects for treating depression and anxiety. And we know that about half of folks who present for research who have anorexia nervosa are on those kinds of medications. So if they're on them, it's okay, but they have to be willing and able to safely be tapered off of those medications. And that can happen with their own provider. That can happen with us potentially. It's sort of a conversation. It's not a disqualifier by any means, but it's something that would have to happen before they received any study drug. So there's some psychological sort of exclusion criteria. So if they have a history of bipolar disorder or schizophrenia, or they have a first-degree relative with any of those conditions, that's usually a disqualifier. And that comes from this history we've had of really carefully selecting people who would be appropriate for this kind of intervention, because theoretically there's a risk that if somebody has a personal or family history of any of those disorders, they might the psilocybin might precipitate mania or psychosis, which would obviously be undesirable. So we really do a careful job of screening out for people who might have those disorders. So the screening process is actually pretty intense. It takes 2 days. We do some medical workup as well to make sure that they look okay. And again, so this is sort of it's a work in progress. At this point, we're sort of looking back and trying to see is this the right approach to be taking? Because there are other exclusion and inclusion criteria. And we're just trying to figure out what makes sense and whether we have the right sort of framework for folks at the moment. And what is the percentage looks like of the people who apply online and fill out the questionnaire versus how many then end up as being participants because they then are able to meet that criteria? Is it really difficult to find people that then meet all of these things?
Yeah, so unfortunately, that is a big challenge. So we have, since we opened up, we've had somewhere around 250, maybe a little bit more people fill out our application online. I'm not totally sure of the very latest numbers, but I think we might have reached out to somewhere between 20 and 30 of them who met initial criteria. And we had, scheduled a bunch of people, but the other problem is that the study is actually very time intensive. For people who are from out of town, it's not always feasible for them to participate, just because it requires so many study visits. They have to be able to travel with another person for some of them, so that we have them designate a pickup person for their psilocybin session days, that they have to be there to get them at the end of the day. And so that can be really financially costly. So there's a lot of things in the way for a lot of people to be able to participate. Unfortunately, some of them are college students, and they can't really get away until the summertime. And now, with coronavirus, who knows if we'll have a summertime? What's going to happen with that? So recruitment is kind of tough, but I think we were going at a decent pace before that. But that's sort of I think one thing is that of the people who we have screened and invited for screening, the rate of acceptance is pretty good, especially compared to some of the other studies we've done in populations like depression, where you have to be a certain level of depressed to be in the study. And the way our criteria is framed right now, or the way our application is, we can usually kind of tell with pretty good certainty who might be a good fit. It doesn't always work out, obviously, and unfortunately, you do have to turn a lot of people away. But compared to for the depression study, obviously depression is a much more common illness, and so we get maybe 10 times as many applications, but a smaller percentage of those seem to be people who might fit for the study.
And from you describing everything that's involved, this seems just so labor intensive in terms of what has to happen for every single participant, in terms of the amount of time that they're then seeing practitioners, then they're being in the room as part of the experience, and then all the follow-up. This isn't just a very simple take this medication and then let us know how it all pans out for you. There is a lot of stuff that goes in to all of this.
Yeah, and that's the case for pretty much every clinical research study that's happened with psilocybin and other drugs like it, is that it's very labor intensive. And you need not just one clinician, but often two in the room with somebody. And that's sort of a big discussion that's happening now, is what is this actually going to look like if and when it gets approved for use? And probably if it does get approved, it would probably get approved for depression first, right? But so what is that going to look like, and how are people going to be able to afford it? Is insurance going to say that they even care to cover it? In one sense, it might be really cost effective, because if you can provide somebody, a chunk of psychotherapy and a couple of all-day sessions, and then do much more further spaced, or intermittently spaced follow-ups, it might actually be more cost effective than paying for medication every month, or paying for weekly psychotherapy for years and years and years. But convincing the insurance companies of that is going to be a different story. And other groups have, thought about ways that this can be a more cost-effective endeavor. There have been a couple other, models that people have tried out. One where somebody only has one facilitator with them, and maybe there's multiple sessions going on at once, and there's a floating clinician who kind of can cover for somebody if they need to leave the room to take a bathroom break or eat their lunch or something like that, But that's going to be a big hurdle, I think. I imagine that initially when this comes out, it's going to be kind of unfortunately, a boutique kind of treatment that not very many people are going to be able to afford.
And are you fairly hopeful that this is going to amount to these drugs being re-brought back into things that could be used as part of therapy? Does this in some ways feel like it's it will just happen? We've just got to get the research to make it so.
I'm cautiously optimistic. The early studies look great. But there have been other examples in research studies where something is brought to phase 2 and 3 and it falls apart. So I don't think that's out of the realm of possibility. You know, like there are a lot of criticisms of the design of these early studies. They're very small. You know, like on the one hand, we carefully select our participants. On the other hand, we carefully select our participants. So once this is brought into a larger pool of people, we might run into problems that we hadn't come into before, right? And we sort of might find that there are some risks that we hadn't foreseen. And that's, you know, hopefully we figure that out along the way in phase 2 and 3. But if we get some reasonable results in phase 2 and 3, and I think even entities like the FDA in the United States are kind of optimistic, right? Because we've now got fast track designation from the FDA for psilocybin for major depressive disorder. And what that means is that, you know, the FDA is going to, well, my understanding is they're going to work with us to try to facilitate some of the work that we're doing and expedite some of the paperwork and things like that the FDA has to do. But the other part of this is the legislative part. You know, under the Controlled Substances Act, psilocybin is still a Schedule 1, meaning that the government at this point in time, even though we have these nice studies, still sees psilocybin as something that has little to no benefit, really no benefit, and a lot of risk. And so the other part is going to be legislative and making sure that the government actually reschedules this substance.
Does that feel like a big hurdle? Because my sense is if it gets to stage 2 and stage 3 and it's all really promising and it's for dealing with mental health issues, which is a huge crisis at the moment, that I don't know, maybe I'm just being naive, but that feels like it should be fairly straightforward.
I would hope so, you know, but again, I'm cautiously optimistic. I'll believe it when I see it.
Okay.
And there's a number of ways that could happen. You know, it could be like an executive order. It could be through Congress. But, you know, there's still a stigma for some people with substances like this. And, you know, I can imagine that some conservative lawmakers might not be all that enthused about making psychedelics available for treatment. But I do think times are changing very quickly. And obviously, if you look at what's going on in the private sector, there's already people raring to go and sort of setting up the facilities and the infrastructure to be able to deliver this kind of treatment at the next day after this is approved. So I think signs are pointing to yes, but I'll believe it when I see it.
Right. And in terms of this study, I mean, coronavirus is messing with everything, but was the idea that this would be done, did you say 3 years before? Was that, or was it just 3 years to get all the people that you need and then in whatever extra time you need to then actually publish and crunch the numbers, et cetera?
Yes, I'm hopeful by 3 years we should be able to have that done. Again, with coronavirus, who knows, you know, we might be stalled for longer than we had imagined, but I guess we'll just find out along the way. But hopefully in 3 years, we should have this preliminary data. And, you know, the other question is like, well, what does that mean for using the substance if and when it's approved? Because if something gets approved, there is such a thing as off-label use for a lot of psychiatric medications, and there's the possibility this would be used off-label. So, you know, it's not necessarily that we're going to have to do this pilot study and then this big phase 2 and 3 study for people with anorexia. That would be great if we could. But it might, you know, this would just sort of provide some preliminary evidence about whether this is feasible, whether it's safe, whether it's effective at all in this population. Because that's sort of the other thing. We don't really, it's a nice idea, but we're still testing the waters as to whether this makes sense and whether this actually can help people make the changes that they want to make.
And you said before about like the screening process has meant that for a lot of studies, it might not be a broad section of the population. And so once it gets into bigger trials, there could be things that come up as part of that. So as part of your screening and trying to get participants, is there a real push to, okay, we want to have this real mix of diversity of people who are then part of the study? Or is it more like, let's keep it as homogenous as possible, so at least we know within that population group we have an understanding of how things work?
Yeah, so I think I certainly would like for our study population to be more diverse. And the counterweight to that is the fact that we're working in a very high risk population. Psychologically, medically, there's so we do have to exercise quite a bit of caution with who we select for this study, at least for this very early phase of it, right? Because we've sort of worked with the FDA to develop a set of rules that we're going to follow about screening and making sure that somebody is medically well enough to undergo, certainly of all the people who have run through the center and other studies, we've shown that psilocybin can pretty reliably be given safely. But because a lot of these folks have issues with, low heart rate or changes in their electrolytes, and they might be more prone to cardiac events or all sorts of other medical issues, we do have to be very careful on how we select people. But in terms of we try to be diverse in terms of other co-occurring disorders, as long as they don't have a history of bipolar or schizophrenia spectrum issues. We try not to discriminate in those terms, and then that way I think we are getting at least something that resembles a representative population of people who clearly are struggling with issues with eating and overexercise.
And in terms of where you're at now, I don't know how much you can say because it's still in the midst, but yeah, is there anything that you can comment on in terms of what the findings are or what you've noticed with the little participants that you have had? Yeah, so in some ways it's kind of similar to what we've seen before, and in other ways it's pretty different. So what's similar is that everybody's experience is wildly different. You can't really predict what somebody is going to experience from any information you have beforehand. So there's been quite a diversity of what people are reporting and what their session day looks like. It is too soon to say whether we have any clear patterns. One consideration is that if you think about our studies in depression, right? We've shown that this can have psilocybin can produce a very rapid antidepressant effect that's long lasting, and has benefits for anxiety as well. But if you take somebody who struggles with their eating and with their exercise and uses that as a coping mechanism, if they start to work on those things, understandably, their anxiety and their depression might go up. Yeah. So that's sort of something we're trying to understand how best to work with and how best to measure. And the other thing we're trying to understand is what dose makes sense for this group, because, as I said, anecdotally, there's evidence that people with anorexia nervosa are less sensitive to these medications, and we are still working on figuring out why that is. And it's not the case for everybody. We've certainly had people in our study so far that have a pretty classic sort of response, but for some other people, it's been kind of different from what we were expecting. And we're not really sure why. For some people, it might have been because so if somebody's on antidepressants for a very long time, this applies to people with depression as well, or anxiety, there might be longer lasting changes in the brain that happen. So even if you taper somebody off, there might be things that still can affect the body's response or metabolism of this drug. And the other consideration is if people, is part of the reason that people might be less sensitive, is it due to just physiologic changes associated with starvation and being undernourished? And we're working on how to best work with that or try to understand. And, looking at the folks we have run through this study so far, we're trying to understand how the severity of their symptoms, their co-occurring issues, their recent use of other pharmacologic agents are coming together. It would have been nice to be able to continue with our handful of other people who we had planned to run this month, but for now we're taking a look at the data, laying it all out on the table, and trying to figure out if there's anything we need to do differently. And with the people that you've had, is this the time, or with each of the sessions, Is that the first time that they've had psilocybin? Because I know it's obviously illegal, but a lot of people have used these things recreationally. So just like getting a sense of, is that more of the kinds of people who are putting their hands up to say, I want to do this because they've had previous experiences or not necessarily?
So people with anorexia in general, I think, have a slightly lower prevalence of ever having tried psychedelics, but we have had some applicants who have had it in the past. In general, we're looking for people who, if they have had it, haven't had that much of it before, or might have, like taken it but didn't really respond, or took it years ago, a handful of times or something like that. But for everybody we've run so far, they are hallucinogen naive, so they've never had anything like this before. And in some cases, it's kind of surprising because like somebody comes to you and they're, totally sober. They don't even drink alcohol or smoke cigarettes. And they're like, yes, I want to do like psilocybin, which is like it's like a varsity level, substance in a lot of ways. But they're open to it. And they, so I feel like I have to commend our participants in that because they sort of go into it with a really great mindset of being really open. We sort of try to foster that in our preparation, be like, the way that you can make the most of this is to just be open to whatever the experience has to offer.
Yeah. Is there anything I haven't asked you about the study or that we haven't chatted about with it that you wanted to mention?
Usually, we talk about like risks of using psychedelics, right? Because we've talked about all the very nice sounding benefits that have been demonstrated in some of these early studies, but usually I do try to stress the fact that like these are, they're drugs, they're medications, they have side effects. And we are still at a place where we're really learning what the risks are. Like we've had all these smaller studies, but we still don't really know what's going to happen as we extend the population in which we use these drugs. And there's certainly a possibility for serious adverse effects. And, while they've been fairly mild in the hundreds of sessions that we have done at the center with other populations, we don't really know what that's going to look like for people with anorexia nervosa yet. There is a possibility that people could get worse, like I said, if you're working actively on changing your behaviors, that's inevitably going to be anxiety producing, and very challenging. And doing it in a supportive setting or supported setting is really probably the safest way to go about it, especially as in this early stage while we're still learning about it.
And with the risk, is it from what you're saying there, at least, more psychological as opposed to a risk of toxicity?
Yeah, so the risk of actual toxicity, like physiologic toxicity, is very, very low at the doses that we're using. But people can have some somatic issues that come up, like blood pressure is a common issue that we run into constantly. So we monitor throughout the session day what's happening with somebody's blood pressure. We actually tend to screen out for people with serious blood pressure issues because it's a safety issue. People have like headache in some cases, though that's usually quite mild. Like if you look at studies of what happens to people who are using just psychedelics out in their normal environment, right? Something like 10% of people have reported that they might have put themselves or somebody else at physical harm as a result of using a substance. So they might have been like driving under the influence or, caring for a child or something like that. So there's like a lot of unsafe situations that could happen. And so we really stress the importance of making sure you're in a supportive environment. People do experience significant distress. And if you're not in a supportive environment, that can lead to challenges down the road. In many cases, people need to, seek some help from a professional. And we just want to stress that this is, it sounds great, but we're still learning about it, and there's still a lot we don't know. And if this is ever going to make it to being available as a treatment for many people, we just have to we have to tread carefully.
Yeah, I know. So people don't rush out and get psilocybin and do it on your own. It's like doing it in the right set and setting as part of research at this stage, because that's really the only legal way of doing it.
And there's obviously like the legal implications and things like that. And, and again, there have been many examples of treatments where they looked awesome in these early studies and then did not look so awesome once they made it to phase 2 and 3. And so, like as a clinician, people ask me about it all the time. Like in my clinic, like, oh, is this something I should do? And I say, well, like we just don't have the evidence, the standard of evidence that we need for me to be able to say to you, like, yeah, you should go off and do this for sure, because we just don't know at this point.
Yeah. And so anything else that I didn't ask or we didn't cover yet?
That's kind of it. I would just say, we're in limbo due to coronavirus, but you guys can, folks can still check out our website. It's www.hopkinspsychedelic.org. We have a mailing list that goes out quarterly that people can join, get updates on our studies. We're going to have some survey studies up soon. I think there might already be some up there that we would love if folks could help us out with, especially if they have, usually the survey studies tend to be for people who have history of psychedelic use. And they can find out more about our anorexia study there and fill out an application. We're still reviewing applications at the moment. So yeah, folks are sitting around at home and are interested. That's one thing they can do.
Okay, perfect. And yeah, I will put a link specifically to all of those things, but especially to the Anorexia Nervosa study and the application form as part of that.
Cool.
Perfect. Well, look, Nelly, thank you so much for your time. I hope the coronavirus pandemic comes to an end so that you can get back to doing this research, because, yeah, I'm really interested to see how this all pans out. And like you, I am cautiously optimistic about this and would like to see a time where this becomes a treatment that is on offer because it is proved to be effective.
Yeah, thanks a lot for having me on. I really appreciate it, and I hope I hope this is over, and I hope that you and your listeners stay safe during this time. And we'll see what happens with our research. Hopefully, we can get back on track soon.
So that was my interview with Dr. Natalie Gukasyan. If you're interested in potentially taking part in the study, then please go to hopkinspsychedelics.org/anorexia, and you can fill out an application form there. As I mentioned at the top of the show, 7 Health is currently taking on new clients. If you're struggling with dieting, with disordered eating, with eating disorder recovery, with body image issues, or any of the topics that we cover as part of this show, then please get in contact. You can go to 7-health.com/help for more information. Lou is doing next week's episode, but I will be back with the one after that, and I will catch you then.